Our first speaker is Dr. Indermohan Rastogi. So he is speaking on reaching the unreached. Where are we? Over to Dr. Inder.
Good afternoon. Reaching the unreached, where are we? At present, where we do stand and what we need to do. Basically, these days, reaching the unreached has become a word in every sector. Whether it is a, you know about smile train, whether it's a blindness or whether it's a poverty elevation, any cause, any social cause, there the word is used, reaching the unreached. So reaching the unreached is basically a dynamic, evolving process which always requires innovation to reach the last man, the last beneficiary standing in the last row. And the needs of the unreached are always central to the innovation which we want to implement over here. To reach the unreached, a system-wide coordinated approach combining national and global evidence and the capability of the local level adaptation is required. Means we have to work at the national level, we have to work at the global level, and of course the local level is mandatory. And in this, the three priority action areas are that we have to strengthen the primary health. Regarding the blindness, we have to strengthen the primary healthcare system so that enhanced inclusivity and equity of the participants is there. We have to empower the communities and individuals to foster health promotion and participation. And we have to address the socio-economic determinants to tackle barriers in the health service access. So these are three things that we have to involve communities, we have to do health system and health services, and of course the political will is always required. And these basically three things they require, they have to be integrated into 5 transformative domains. That is, we need to have political commitments and the multi-stakeholder engagements. Everyone has to be involved. And of course, the data-driven decision-making. We have to take the feedback, we have to collect the data, and only then we have to decide upon the policies. And then, of course, health service evolution. We have to integrate the techniques as well as we have to provide the latest technology so that the results are not bad. And we have to have special innovative approaches. That is basically, as I told you, the dynamic process, and we have to have new innovations into this system also. So this is basically five system approach. So for community engagements to contribute to effective change, efforts need to go into defining the goals and the purpose, why we are engaged into it, and working out the most effective strategies to realize our goals. Then, up to what extent the policymakers and providers are willing to share power and implement change so that we get the desired results. And of course, we have to have the trust in the community so that we can penetrate and we can provide the care to the last one. As far as this blindness is concerned, we have been using all the data. We have been, but the latest one is rapid data by Dr. Praveen Vasisht at AIIMS, which was published in 2022. And for that, the blindness is less than 3/60 in the best eye. They have created another category that is pinhole blind, means best corrected again less than 3/60. And there is a category of functional low vision also. So at present situation in the world is there, that is over 6 billion, suppose this is the situation, that in the population of 7 billion, 6 billion are users of the mobile, and still the 4 billion of the population in the globe is still unreached by this connectivity. But what about access to the health? What about access to the eye care facilities when providers are so less and demand is so high? And again, the uniformity of the healthcare which is not distributed. So we have to think for that also, that we have to provide access to the healthcare. And as far as blindness is concerned, it is a significant public health problem, which is, global problem, and disproportionately large prevalence in the low and middle income countries. So again, as far as the scenario of the India is concerned, it is a public health problem, and around 5 million people are blind, and 70 million are visually impaired, and of course, 0.24 million people, the patients are children. By literature, if you go, India is known as the blind capital of the world due to its high prevalence of the avoidable blindness, especially the elderly population, which is almost non-productive, but children population which is involved, which is going to be the productive population. More than 1/4 of the person aged 50 years and above are visually impaired. So India and China, they account for 49% of the world's total burden of the blindness and vision impairment. And as far as their population is concerned, that is 37%. But they are contributing around 50% to the blindness. So we need to have improvement in Indian scenario of the blindness so that the global burden of the eye disease is reduced. So IAPB says that India possesses the maximum number of the people with total vision loss and the blindness, and 80 to 90% of this blindness can be prevented by simple medical attention and awareness. The two things which is being emphasized always and everywhere, that is cataract and refractive errors, they top the cause of the blindness causes. And again, survey says that the rural areas are more affected, and because of the higher population and which is difficult to reach areas. Rural and tribal areas, the lack of the ophthalmologist or proper infrastructure again, delays the diagnosis. So this is basically the area of the crux. And these are the major causes by RAB survey, that is cataract, opacities, and of course these days surgical complications is contributing to lot. And glaucoma, 5.5%. The proportion of the blindness and visual impairment is such that due to avoidable causes, the visual impairment is 97% itself. So in the ongoing process, India has made significant strides towards the elimination of this avoidable blindness, and as for the latest data of the RAB, it has reduced up to a significant extent. So what are the factors which are affecting the eye care? Everything is affected, but one thing is most important, that is demand-based factor. They are contributing a lot. That is, जरूरत ही नहीं लगी जी, no felt need, lack of a person, हमारे साथ कोई जाने वाला नहीं था, या सर्जरी में डर लगता है. So they say that 80% of the people who are seeking attention, the medical, they need medical care as far as the blindness is concerned. These factors work over there. So we have to, allay these fears. We have to go into the society, and we have to do the cost-effective, care for them. So another concept is case finding and treatment initiation cost concept, which is new these days. Case finding means starting from the case to the treatment initiation. How much is the cost incurring on that particular patient, and inclusive of everything, that is spectacles, corrective surgeries, everything. And even this concept involves engaging the population in the risk diagnosis with visual impairment and converting the diagnosis to the treatment also. On one side, as far as the urban population is concerned, access is not the problem. In the rural, remote areas, access is still the problem. And so most of the factor, cost effectiveness in the India is the cost of the case finding and treatment initiation in the last person standing in the row. So we have to have direct our strategies on this particular aspect so that the blindness, the prevalence of the blindness is decreased and in the region as well as in the world. Pivots of the approach in the community is door-to-door screening. And another concept is school screening. We want to, diagnose the blindness, the refractive errors in the children so that our productive population is not affected. So keeping this thing in mind, these days, the vision center has become the nodal point, slightly shifting the role of the camps. Earlier used to be the camps once in a month, twice in 2 months, 3 months, एक कैंप होता था गांव में एंड देर सर्जरी जो मिली वो कर दिया. नेक्स्ट टाइम जब तक कैंप लगता था कुछ पेशेंट्स ब्लाइंड हो जाते थे. बट दीज डेज गवर्नमेंट NGOs दे आर डेवलपिंग द कंसेप्ट ऑफ द विजन सेंटर. So that person, optometrist or assistant is available over there round the month, round the year, round the day. In the community, he can diagnose the patient, he can, diagnose the disease and surgery is advisable or the blindness is cured. So there comes the role of the teleophthalmology. How he is doing? He is sitting at the remote place, but he is giving the diagnosis or correcting the disease with the help of the teleophthalmology. So these days, again, the screening camps, only screening camps, not surgical camps, and vision centers, they are becoming the most effective cost strategies for identifying and encouraging individuals to undertake the corrective eye surgeries services so that cost-effective service is provided. What are the areas of emphasis? It is required, we have to require the eye banking and corneal transplantation on the other front. Through vision centers, we are putting emphasis on the community and school health services. And of course, with this, we have to improve our surgical side effects also. So refractive error screen is the must or becoming a point of the emphasis. So we have to see the role of the teleophthalmology also. Teleophthalmology is again becoming affordable and feasible tool for providing eye care delivery, especially in the rural, tribal and remote areas. And of course, in the whole of the country where the end user is to be benefited. It is a workable model in ophthalmology practice as well as saving the substantial cost to the community and to the provider also. And it is beneficial in so many things, that is screening, consulting, counseling, prioritizing the patients, optimizing the medications, supervisions also, follow-ups also, education also, emergency services also. So it is particularly useful in remote areas or rural areas where specialists are not available and where screening and evaluation is a problem. And so many even companies are helping out. Thank you.
Thank you, Dr. Inder, for highlighting the role of community ophthalmology to cater the eye care services to the population where there is a little need for those services. I think it is a collective, it should be collective efforts of the government, then NGOs and eye care providers. Thank you very much.
Thank you, sir.
Our next speaker is Dr. Jagdeep Singh Basoor. He is Deputy Director and Program in charge of National Program for Control of Blindness and Visual Impairment in Haryana. So he is speaking on micro-planning for removal of cataract blindness backlog under NPCB and VI. Over to Dr. Jagdeep.
Thank you, sir, for the nice introductory words. My special thanks to AIOS and Professor Rastogi, who has always been pushing me for the academic pursuits. Today, I will be speaking on micro-planning for removal of cataract blindness backlog under the program, National Program for Control of Blindness and Visual Impairment. A goal without a plan is just a wish. Recently, various campaigns have been proposed, namely Cataract Blindness Backlog Free India, Rashtriya Netra Jyoti Abhiyan, and Pradhan Mantri Motiaband Mukt Bharat Abhiyan. Currently, we are working under Rashtriya Netra Jyoti Abhiyan. Assessment is the most important thing for any disease. We have to assess the disease burden. Assessment of available screening capacities have to be done, and assessment of available surgical capacities is also done. According to population and RAP survey, estimated surgeries required for the next 3 years are for financial year 2022-23, these were 1,09,000 for Haryana and 75 lakhs for the country. For the current year, these are 1,31,000 for state of Haryana and 90 lakh for state. For the coming financial year 2024 and 25, proposed surgeries are 1 crore 5 lakhs for the country. According to data available in the 2022-23, we could achieve 193% of the target in the state, and nationwide we could achieve 83 lakh 44,000 surgeries as against 75 lakh. In the current year up to January, we have already covered more than 100% for the state of Haryana, and at national level we are at 73%. We have performed 66 lakh surgeries as against the target of 90 lakh surgeries. HR is very important for any program. For primary screening, we need ASHA workers, Anganwadi workers, MPIWs and volunteers. For confirmation, of course, optometrists and ophthalmologists are needed. For treatment, surgeons, OTAs, nurses, etc. are required. We need finance for the trainings, ASHA incentive, TAD, etc. and for surgical consumables. We have to do trainings for the primary screening, ASHAs, ANMs, etc. will be trained. For confirmatory screening, paramedical ophthalmic assistants and ophthalmologists are to be trained. We have to build cataract surgical capacities at government and NGO facilities. Infection prevention protocols need to be developed. Follow-up protocols are also to be developed. We need certain logistics for the screening and treatment, stationery, torches, Snellen charts, vehicles, consumables, and surgical equipment, etc. are needed. We have to map the services available. District will be a planning unit. Primary screening will be household survey with special emphasis on 50+ population. For confirmatory screening, referral linkages will have to be set up, and a blind registry have to be maintained for identified patient for cataract surgery. And mapping of surgical caseloads and surgical capacities is also to be done. Public made to be aware by IEC through Munadi, pamphlets, miking on rickshaws, and announcements from Mandir, Gurdwara, etc. Community participation is important. We have to motivate Panchayati Raj institution members, religious leaders. In urban areas, we need to collaborate with senior citizen associations and resident welfare associations. Intersectoral coordination is very important. We have to involve education department, women and child department, development and Panchayati Raj department, revenue officials and municipal councillors, etc. Monitoring will have to be done from bottom to upwards, from the block level to district level, from district level to state level and independent authorities. Reporting will be done from block level to district level to the state level, and from state level to Government of India level. Evaluation of the program will be done by independent agencies. First of all, block or district declare itself a corneal cataract blindness backlog free as per given parameters. The cataract surgical coverage should be more than 98% for the blinds. The post-operative complication leading to the blindness should be less than 2%, and visual outcomes should be good as per WHO criteria in more than 95% of the operated cases. Evaluation will be done by independent agencies. That is state level, which will include Government of India representation, and finally the WHO or AIIMS-like authorities will evaluate the total outcome. After the evaluation, state will communicate the results to the Government of India, and Ministry will get these verified from the independent agencies. Certain incentives, cash prizes and medals, etc. have been provided for the states and districts. These will be judged on the quantitative criteria, that is cataract surgical rates and cataract surgical coverage for the visually impaired. And qualitative criteria will depend upon the surgical outcomes. For each district which will be declared cataract blindness backlog free, 10 lakhs will be given to that district. Let us all get together and make sincere efforts to achieve the target of cataract blindness backlog free India. It is a team effort, and I'm sure we all can do it. Thank you.
Thank you,
Any
Dr.
questions?
Jagdeep, for highlighting the micro planning for cataract blind free India. So, and also showing the excellent performance done by your state of Haryana under National Program for Control of Blindness and Visual Impairment. Thank you, Doctor.
Thank you.
Our next speaker is Dr. Manisha Rathi. She is senior professor in RIO Rohtak. So she is delivering her talk on low cost, affordable eye care and blindness. Dr. Manisha.
Okay. Thank you so much for including me in this. And I am really happy to see all the wonderful speakers, and a lot of points which were to be covered by me have already been covered. This is a topic close to my heart: low cost, affordable eye care and blindness. First of all, why are we interested in this topic at all? Because see the magnitude of the problem and the global impact. It affects many households, many cities, many states, many nations and the world as a whole. Even a developed nation is not free from the scourge of visual impairment and blindness. The reasons may be different. More than 2.2 billion people have either a vision impairment or blindness. And the maximum cause of vision impairment in the world is uncorrected refractive errors. 36% of the people who have refractive errors, visual impairment, have access to an ophthalmologist or to spectacles, and 17% only with those with cataract have access to medical facilities. There are socioeconomic differences, regional and socioeconomic differences. The countries which have a lower per capita income have a 4 times more incidence of visual impairment and blindness. All these studies are from the last 5 years only. So what is the impact? The impact may be social, financial, personal. If it occurs at a very young age, there will be developmental problems such as delayed motor, language, emotional, social, cognitive development, which will finally lead to underperformance and academic underachievement. If it happens in early adulthood, then the quality of life is affected, and a lifelong effect of loss of employment, which affects the whole family as well as the individual, and there may be rates of increased worthlessness or depression and anxiety. If it happens in older age groups, there will be social isolation, There may be falls due to decreased vision, fractures which are very difficult to heal. So they may be put in assisted caring facilities earlier, which again has a huge financial impact. So the economic impact is enormous, and it's about US $411 billion. I don't know about you. I don't know how many zeros are in that figure. If we convert it into Indian rupees, how many zeros will be in those crores? I am not aware, but it is a staggering amount. So what are the strategies? We can't just take it that, this is a global phenomena and it happens more in poorer nations. What are we doing about it? The effective interventions are you can promote, prevent eye health care, or treat, and finally if there's irreversible visual field loss or vision loss, we can rehabilitate. Each of these are important. Many things such as trauma with increased education to the public and infections, if treated early, can prevent long-term complications. Traditional medicine should be discouraged without any supervision. Perinatal health should be improved. Nutrition-based diseases can also be cured, and self-medication should be avoided. Early detection is very important in irreversible blindness. The number one leading cause of global irreversible blindness is glaucoma. So screening for glaucoma and diabetic retinopathy, there are many nationwide and statewide programs for that. They are crucial to prevent blindness in patients. And of course, visual impairment, the leading cause is spectacle loss, lack of spectacle access to patients. So we should start screening for refractive errors in a younger age group and in an older age group as well. Quality surgery should be provided for cataract. So the leading cause of treatable blindness in the world remains cataract, whichever the country, and irreversible remains glaucoma, and now followed by diabetic retinopathy in a lot of countries. Dry eye, conjunctivitis, blepharitis, while they are not blinding, can really provide discomfort to the patient and have symptomatic difficulties which may interfere with their work. So it's important to treat these conditions as well. We are not just aiming to promote blindness, but the quality of life as a whole. And visual rehabilitation, if all is lost in the vision, we can still have visual rehabilitation. There's a WHO response which was adopted at the World Health Assembly in 2020. This was guided by the recommendations of the WHO World Report on Vision 2019 and Resolution on Integrated People-Centered Eye Care. This is IPEC, including preventable blindness and visual impairment. And the key proposal is to make integrated people care centers and ensure widespread. There's widespread, there's a W missing from this. Normally I leave a slide out so that somebody can point out, but this is a postprandial session in which people may be sleepy, so I'm pointing out the deficiency. A W is missing. So widespread, just to wake us up, widespread implementation. The report and the resolution, Dr. Basur has just told you how reporting, what indices are taken and how reports, because it's important to implement and to see what is happening. It's not enough to just put it out there. You have to assess it, improve it, and make sure it works. So some of the WHO key areas are monitor the global targets. They have been set for 2030, and on integrated people eye care centers, the reports are done, eye care indicators are taken, and the measures which are helpful. So we observe World Sight Day as an annual event so that it reminds people that sight is important. Although every day, every moment, from the moment you open your eyes in the morning to closing them at night, you know sight is important. You support integration of eye care and health systems. Then the eye care for health systems guide for action, the package of eye care interventions, and the eye care competency frame. The eye care, there are several tools which will help. So several toys at our disposal. Eye care situation analysis tool, assessment of diabetic retinopathy, assessment of glaucoma, refractive services. As you can see, these are the three leading causes globally of visual impairment and loss. Assessment of rehabilitation services. There's a myopia ed tool, which is a mobile health toolkit for myopia to increase health literacy, and graphics which promote healthy eye habits. So for cataract and glaucoma, we right now have the World Glaucoma Week, which we are observing. We have conducted eye camps, radio talks, glaucoma walks, distributed caps, poster competition, slogan competition, all to encourage, and have been doing screening for 40 plus or susceptible individuals. So this was a screening we did at ICCUS camp. Yes, patients are very happy to pose because they only said, one of them suggested these ladies, कहते जी ये क्या photo खिंचाई, ऐसे करो जी. So he took a picture like this, and this was 825 patients screened, and mobile number of my student was Dr. Anshu Khatri and Dr. Sakshi SR. These mobile numbers were distributed freely that they will contact. They said, please give us the address. We don't know where to come. They are only 50 kilometers away from us. So we have given, after the mobile number, there is a great sense of security that we will be seen. So they are coming to the OPD. Even now if I am here, patients are landing up at the OPD to get screened. Small incision cataract surgery is affordable, effective, and this is a study published by us because the main concern may be surgically induced astigmatism, so this may be minimal. This is an elderly patient. You can see hypermature cataract ready to burst, the zonules are weak, the capsule is weak, so I have just done the chevron incision because this patient had 0.25 with the rule astigmatism. At the end he had 0.25 against the rule astigmatism, which is considered to be beneficial nowadays. And this person was not concerned about astigmatism. The cause was lack of finances and lack of people to bring them to the hospital. So this surgery was done after staining the capsule. You can see the release of fluid, and this is the calcium. The whole lens is moving. It's a solid lens, so you have to be careful. I've completed the rexes, and now this division. My main concern was to bring this nucleus out and not let it go back, which SICS is more forgiving in this respect. And of course, indigenous IOL was donated by us. So these are the expectations, one-to-one, people will see us, and this is how it will be. The reality is this, and of course, the right picture at the end is our OPD on any given day, and because of this, we are lucky, we are blessed we have this many patients coming, and thank you so much for giving me this opportunity. Thank you, sir.
Thank you, Dr. Nisha, for wonderful talk, and I think we should promote low-cost, affordable services to the community, and these services should be available to even to the remotest area. So thank you very much.
Thank you.
Any queries from
Please
the
ask something. No, and the eye camps are being done in our institution. The eye camps are being done. So for patients who are below 50, phaco is being done. But above 50...
Specific guideline regarding doing phaco, is there any guideline?
No, we have not received for the eye camps. Basically, we are documenting what the success rate is and monitoring closely. Senior consultants are always there. This is done on Sundays. You get, supposing 100 patients. So 25 patients will be done on each Sunday. And in 2 shifts, leisurely, autoclave being used properly, disposable like any other patient. And if the patient is like this, then we prefer to do SICS. And in a younger patient or a patient who wants a specific kind of lens or whatever, that is also donated by them, they can choose. They call it laser wali surgery, which is a misnomer, but that is also available.
Regarding guidelines, it is very clear. MPCP program gives 1,000 for each free surgery. Of course, it is not being paid to the medical colleges. For government hospital, it is 1,000, and for NGOs and private hospitals, it is 2,000 per surgery. Whatever you can do in that much money, you can. In civil hospitals of Haryana, we are doing phaco with hydrophilic foldable within this budget.
So we can plan surgery according to the affordability of the machinery, equipment, and other logistic and consumables present in our institutions. Government of India is giving the fixed amount as Dr. Jagdeep told us. Thank you, Dr. Manish. We should promote low-cost, affordable eye care services to the community. So our next speaker is Dr. Kanshuk Marwa. He is a vitreoretina surgeon based at Gurgaon. So he is speaking on NGO and private setup role in curable blindness. So he is imparting community services, especially to the diabetic patients and other retinal diseases in the private sector.
Very good afternoon to the eminent dais, and it was a pleasure seeing everybody's guidelines and the work which is being done. So I'm going to talk about NGO and private setup role in the curable blindness. We had previously seen Dr. Rathi's work in the RIO, and the amount of mammoth of work they are doing. But the balance is not there. The urban people also have, a lot of load of blindness, and they also are not aware. The education is lacking. So definitely the movements like the glaucoma awareness and these things really help to educate people, because people in the urban places are also getting blind. So why is that? That is because of the lack of education and communication between the doctor and the patient. So already we have discussed about the mammoth load of blindness. So 771 million people in the world can have a preventable blindness, which can be actually cured by glasses or by simple methods like trachoma care and other things, which are still existing. It is not that they have been completely eradicated. So, and the 77 people are curable blindness of cataract and other things like age-related macular degeneration, glaucoma. So, and the statistics in India, there are estimated 4.95 million blind people. So, the data will be increasing every year. It is not going to decrease. All the data that I have seen on the internet is all the previous data. So, in the statistics, you see this the red bar, the pie, which is actually the cataract load. So the cataract load is definitely the highest number of blindness. These are the states. You can see the Haryana also in the orange sector. So the darker color is the load of blindness in the various states. So and Delhi NCR areas are also into that. And right from the college days, I think camps are being initiated. So this is my photo from the college days when this was my first camp, which I did in my college days. So I just have kept this photo with me, and still, it is, I share it with everyone. So when I started my practice, we made sure that the RWAs and the neighboring societies, we used to do every Sunday, we used to do a camp. And we used to make people aware about glaucoma. So how can we private clinic people help in the prevention of blindness? So there are so many people who require financial support. So the kids around our neighborhood which cannot afford glasses, so we make it sure that we give them glasses and take care of that. So that is not a big costly affair. So that can be done and taken care. So these are the kids which are evaluated at our clinic. And we also partner with the general practitioners in and around the urban areas, and we hold on one Sunday in every month, and we conduct a diabetic retinopathy screening camp at a cataract screening camp. This was done in Chhattisgarh. We also partner with the neighboring schools. Like I am a pass out of Don Bosco, so we keep one screening camp for the students who require checkup, and that is being done routinely. And the glaucoma awareness walk helps to make people aware of glaucoma in and around our city, and most of the people have collaborated with IMA in Gurgaon also to conduct free eye pressure checkup for the doctors as well as the other people around the neighboring areas. And various religious activities, like sir also said, with the Gurdwara communities and the temple communities, we can collaborate and keep camps regularly. So this was, and also we have big shopping areas in the urban population areas. So this is one of the areas in Nehru Place. So there also we conducted big camps along with the shopper community. So they helped us to give an area, and we conducted the eye checkups there. So, and with various hospitals also we collaborate to provide free eye checkup as an individual doctor. And like various NGOs like Satya Sai and Radha Swami Satsang and even Delhi Police, and we have conducted camps in the police stations and in the and wherever they have the booths. So we keep an area there, and we have conducted with one of the NGOs in Delhi, and we have conducted eye screening there also. So these are the Radha Swami Agra medical camp, which is done in Delhi and NCR in Faridabad, Gurgaon and Noida. And we also organize with the local Christian charity missions also, and we conduct eye screening there. And a very good team is also very essential. Like ma'am is also saying, like she is here and still the IMs are being conducted. And like sir also mentioned about the Vision Center. So we also have our optometry team which will be conducted screening this Sunday also. So when I am in the conference, we are screening people in Gurgaon and other areas. And this was a program which was done by the NPCB. So in the Delhi Southeast district, we conducted a screening of 6,000 children, and glasses were given to the kids. So this was also within the NPCB this thing, and the spectacles were distributed to the children, and I saw the disparity and the myopia progression which is happening in the society. So that is also one cause of concern, which is the future concern, that the myopia is also progressing in our population along with cataract. So private eye screenings being done in Gurgaon in Haryana. And these are the eye screening done with the local PHC in Tughlakabad area with the tie-up of NPCB. And we also have a program of actually, taking refurbished frames and putting new lenses and giving to the patients. So we get a donation of old frames and we put in new spectacles and give it to the patients. And so we don't let any patient go, because if a patient is coming and you are diagnosing, like sir also told that if you have diagnosed, then better treat them also. So we get the funds from local charities, and we do cataract surgeries at our clinic also. And I think most of the doctors here are doing this. And even kids with ROP, people who could not afford, we have done laser for a few of the kids and diagnosed them. And we didn't charge anything from the parents, so we are trying to prevent blindness at that prematurity level also. So we know the role of the NGOs. NGOs are also doing a big role. So there are various NGOs which we are aware, like Shankar Netralaya with the Jaslo Community Ophthalmology Care. They also provide ophthalmology care to families with less than 12,000 per month. Institutions like LVPI, which are doing a mammoth of work in the South region, along with the Arvind Eye Hospital. Their model is a model which has been discussed and replicated all over the world. And Shankar Eye Hospital, I've been an alumni of Shankar Eye Hospital, Coimbatore, and they also have a very nice model where the 20% are private surgeries and 80% are the surgeries for the poor. And various supporting NGOs all over India, Rotary Eye Hospital and Lions Eye Hospital, you see almost everywhere. And the Seva Foundation, they are also working globally and conducting eye camps. And they also distribute spectacles, and nowadays they are doing diabetic retinopathy screening also. And there's another trust in Gurgaon, Lala Ram Chandar Memorial Trust. They are also doing a lot of work in the Haryana area under Professor Dr. I.M. Rastogi, which they distribute spectacle and medicines, and they conducted a lot of CSR projects. And we've been associated with the Bajaj Eye Care. They are also doing a lot of eye care surgeries with Rotary and several camps has been done in Panipat. And future trends is that the AI is evolving, and we can actually screen diabetic retinopathy through AI. And there are various tools which are coming where we can just take them to the camp, and any optician or any technician can take them and they can screen the diabetic retinopathy in the field also. So those things will be the potential breakthrough. And we have used the same technology with the VOC. We have done the camp in one area in Govindpuri, and I screened the patients in my clinic in Delhi. So this was done through the telemedicine. And similarly, there is something called the 4-eye vision. This is a work by Dr. Croy. So she has lenses, which are ready-made lenses. So whenever we see patients, and we can give them glasses there itself. We don't have to ask the patient to come again, because the patients cannot come, like ma'am is saying, they're traveling 50 or 100 kilometers. So if you are screening them, as well as give them glasses there and then only. So practical perspectives after the discussion is basically we need to have a sustainable community focused strategies. So government hospitals are doing their work. How can private practitioners give their role in this prevention of blindness, which sir has also supported. And obviously education, awareness and early intervention is very important. So we have discussed the key points. So it needs a collaborative effort for sustained progress by everyone's help. Thank you so much. And
hello, it's indeed great presentation, and it's like you are doing this according to like PPP model, public-private partnership.
Yes,
is
yes.
Being supported by the government.
Yeah.
Being like encouraged
Yeah.
everywhere.
Yes.
So in your experience, you have collaborated with the government?
See, like there was the government of India, like the NPCB, they hold out tenders for any evaluation and this thing. So you have to apply for that through the NPCB office.
No, no.
Yeah.
Have you collaborated with the NPCB? Certain decisions like
yes, yes,
doing
for-
ROP and everything?
No, for the ROP, it was a private this thing on my own. So like since I've been in practice since 10, 11 years, there are many of my colleagues, my school friends, they want to help somebody who's in need. So I tell them, I share with them this, there's a case like this, would you like to help in this laser or something? So obviously, they would send the message in their friend group and something will come, and we do it in the minimum, whatever is available, so that the kid doesn't go or we waste time because ROP also progresses very quickly. So if we have anyone who requires any help, we will try and help those people. So that is one thing which I have done in my practice, is never send anybody back for the lack of money. So whatever is possible, we tend to treat that patient and then only send, because doctor is communicating with the patient and the family. So that bond can never come with anywhere else. That story will restart. He'll tell the history and everything. So why not treat the patient there and then only? Yeah. Thank you.
Our next speaker is Rohan Kumar Chariwala. He is from Navsar, Gujarat. He runs an NGO, Shubham Netra Seva Trust, which is dedicated to the tribal areas of Gujarat and Maharashtra. So he is sharing his valuable talk on how to make NGO self-reliant to achieve curable blindness. Over to Dr. Rohan.
Yeah. Thank you. Namaste, Assembly and Chair. I thank AIOS and Dr. Rustagi sir for giving me this opportunity to speak on the crucial aspect of any NGO or any eye care service provider, that is sustainability. So, sustainability is a vast issue. There are so many definitions and all, but ultimately it boils down to the particular NGO, their milieu and everything. So we have to categorize it and tailor it according to one's own needs and resources. So I acknowledge right here Dr. B.R. Samanna sir and Arvind Eye Care System for some of the tips from them. So sustainability is defined as a health service operated by an organized system with the long-term ability to mobilize and allocate sufficient resources for activities that meet individual or public health needs, and it does not affect the future generation also when we are not part of that particular system. So it's like mix of social, environmental and economic parameters. When we are talking about socio-economic things, the sustainability portion is equitable. The equitable distribution must be there. For bearable thing, we need social and environmental interactions, and to be viable, we need economic support along with the environmental support. So the components are technical, social, political, financial and managerial. As far as technical sustainability is concerned, we need to think of staff training, skills. Managerial things includes organization, delivery system, marketing, etc. Financial includes cost reduction, containment, recovery, and most importantly, the leadership of any organization. So as far as financial sustainability is concerned, it's a cost recovery or the fiscal solvency. The notion is to meet all financial needs through internal resources on which the program has full control. Internal revenues must be more than cost of the eye care services, then only it is like sustainable. Financial sustainability has four components. One is cost containment, which includes following, you can see in the busy slide: cost reduction, cost recovery and cost sharing. Cost recovery is like income generation over which we do not have any control, and cost containment which can be controlled. So on the income side, we can see it's a stable source related to the core activity and focusing on the quality and pricing. Expenditure needs good accounting system, good information system, and focusing on the productivity, resource utilization, and its appropriate use. So the same slide, repeating, so I'm just skipping it. Sustainability has 4 components, which is human resource development. If it is good, we can attain that. Good management, good patient-centered organization, as Dr. Rathi madam said, that the WHO has like people-centered eye care delivery. And it must be integrated to the government system. So we need to be working in tandem with the government sector or other sectoral connections. Then comes the cost-effective and optimal resource utilization. Cost recovery depends on the sustainability, marketing, satisfaction, and quality of the care we provide. So we need to be very, very careful when we think of sustainability. It involves so many things. As far as framework is concerned, we have to contextualize the factors. Activity profile of an NGO is utmost important. If one NGO is working in a urban setting and one in a rural tribal, one in hilly terrain, we have to tailor it accordingly. It deals with the capacity, capability and competence, collaboration and cooperation, culture, clarity, camaraderie, commitment, continuity, and catching up with the innovation. As Dr. Marwa pointed out, artificial intelligence, the new techniques must be employed to minimize the resources. So ultimately, quality drives the sustainability, and quality must be assured at all level of eye care delivery as well as at our service programs or projects. So foundation of the sustainable eye health programs that depends mainly on leadership, who is on the leadership position. Then the managerial competence is also very important. Clinical competence is also important, as the quality we give out to the community, the people will have faith in us and will avail the facility. Process to sustain the above are the foundation of the sustainable eye health care programs. So guiding principle for sustainability are as follows: doing what needs to be done in that particular setup, doing it right, having a process that continually ensures the above, having a long-term perspective without compromising current needs. Now the main issue is cost recovery. How it can be done? So cost recovery drivers are many. So one is quality of eye care. Well-trained eye surgeons, doctor and staff must be there. With the standardized protocol, everything must be done. Appropriate equipment and instrument must be used. And for cataract patient surgery, intraocular lens and other consumables must be good in quality. Quality of services also includes timely attendance of the staff. If doctor comes late and our surgeries are delayed and the patient are waiting in OPD, it's like mess we are creating. So that is also very important. Treatment, counseling, patient satisfaction measures, as Sir rightly told us, that the feedback is very important. So regular feedback is necessary. Efficiency, scheduling of the operations as a flow of the patients, planning of the tomorrow and day after tomorrow, or weekly planning must be there. And human resource adequacy and training, the regular training is also very important. Cost recovery drivers includes outreach services also, which includes service marketing. We need to take measures to increase patient volume, addressing barriers to eye care. Counseling services must be strengthened, and we have to manage with the best practices available. And positive ergonomics must be there. That means right people for right job at the right time in the right place, which we learned from Arvind Eye Care System. Policies and standards are up to the mark, whether it is accounting, whether it is management, and we need to monitor thoroughly. Quality and accountability. No Ram Bharose thing. We need to be evaluating our projects, plans and everything. Cost recovery models are many. I am not discussing it. There are so many countries which have successful models. Now comes the demand side financing. Demand side financing are the that channels a part of subsidy for eye care services directly to the patient, allowing them to avail the services. Which are the issues then? it target the poor, lack of the user choice, and no linkage between performance and a provided payment. Patient want to come, but there is no, what can we say, linkages. So now the WHO has also emphasized more on referral linkages. So also the government of India, which has come up with the health and wellness system document guideline, which I am the part or contributor, where we are also discussing this thing, that we need to be having that referral linkages. Without that we cannot do it. As Dr. Rathi madam told, that we need to give them proper contact details. So patient को देखा और उनको यहाँ भेजना है, इस समय पे भेजना है, Saturday Sunday off है तो उस समय, तो that needs to be thoroughly emphasized. Demand side financing needs innovations. Target scarce resources है. Actually India is a resource constrained country, and the magnitude is humongous. So we need to be very careful allocating the resources. It involves the private sector also, links with the government linkages also, preference to users, and output or performance based होना चाहिए. There are some organizations which have voucher system and everything. We have chithi system in ICAM. We give out the cheats and we write down the day on which they have to come with all the preparations. So unka incurring expenses can be saved. Examples are education में invest Bangladesh ने किया, तो Bangladesh could give out good sustainability model. Similar IMR and MMR, Gujarat state, Gujarat, we can learn so many things from them. Now which are the pros then? So pros are, it targets the subsidies, performance linked payments, provide competition and quality, user choice is there, the consumer are empowered, and it encourages innovation, PPP promotion. But which are the cons then? So it needs high administrative cost, complex to set up, targeting difficulties only, so and leakages and abuses are there, collusive behavior, moral hazards and cream skimming, weakening public sector, issues around capacity, skill and system. But if we set up rightly, this can be solved at any time. Health and eye care financing has prime focus on poverty reduction also. So it only treating blindness does not mean that just a patient is seeing the world, but his family and socio-economic condition is also improved. That must be kept in mind. So we are doing a good work. Escalating healthcare cost, further impoverishment can be reduced, protection of low and middle income countries population, because as we are seeing, the India is marching ahead with the development, where the middle class is coming up, and if we take care of their eye care services, they can utilize those resources saved on eye care, can be utilized for other developmental activity and human resource development. So if you want to develop a sustainable plan, you need to ask yourself a question: how do you plan to obtain long-term programmatic or institutional support? Question 2 is, how do you plan to get community support? Third, what will be in-country support, be it for salaries, commodities, consumables, equipments, volunteers? And question 4, at what time this can be introduced? And question 5 is, how does the organization plan to get political support in the form of grants and everything? And question 6 is, describe plans for continued financial support. It's not that you have made a program for a week or a month or a year. It must be long-term program. So strategies involve fees for services, how much fees to be kept, how should we go about it. National and international donors must be considered. Income generation activities needs to be focused. In-kind support must be there. Collaborative intervention must be there. Cross subsidies, consultancy services for fees, self-sustaining activities internally, community network, corporate support, and fundraising components can sustain our activities very well. Strategies for organization or program are institutional vision, mission and values. We should not compromise on that. Staff competency must be there. Institutional evaluation system, feedback system must be there. Regular performance reviews are there, and particular third-party evaluation, as Jagdeep sir said, that third party must evaluate the thing, and we need to be ready with the change, adapt and flexibility according to the community. Community does not mean the poor of the poor. Community means your clientele. All the sections of the society must be coming to you, and you must sustain it thoroughly. So community support must be there. Community leaders are to be taken into confidence. Networking, collaboration is the key. Lobbying and pressure groups must be there. Media management and meetings are very crucial, because little problems will be highlighted in media. So whatever we are doing good must be highlighted now. This is the busy slide, but you can just can Google it. It's like Rodney Knight has designed one sustainability algorithm for Orbis International. It gives everything what I described in my lecture. This is also busy slide. Same thing, you can download it from Google. There are sustainability planning tools are available which are free, and WHO site also having that, so you can download it and you can put your data into it, and you can actually take out what fits for your organizations or hospital. So that ends my talk here. Thank you so much. If any question from your side, happy to answer. Thank you.
Thank you, Dr. Rohan, for elaborating the role of NGOs in achieving the curable blindness, the goal of curable blindness. Any question from the audience?
Dr. Rohan, regarding financial sustainability, I want to know that how much Ayushman Bharat scheme is helping you.
Actually, Ayushman Bharat scheme is helping, at least in Gujarat state, very well. Most of the NGOs are happy. Payments are released regularly, and it is like more than whatever is given under DBCS or something. So in Gujarat at least is going very well, but in other states there are some difficulties of like regular payment and everything, and it requires so many certification and everything. So that's the bottleneck, but most of the NGOs, they can get through it nowadays, because all NGOs, they are now establishing themselves, complying to the protocols. So I think PMJ is giving good results, yeah.
Thank you.
Thank you, Dr. Rohan. With this, we came to end of this session. Yes. So I thanks Dr. Inder Rastogi for conducting this wonderful IC on community ophthalmology. So thank you very much. Thanks for the speakers and the chairpersons, and of course the audience. Thank you very much.